This seminar, we are going to talk about high flow nasal cannula and RAM cannula ventilation. The contents of this seminar, we are going to talk about burden of need, physiology, especially in children, trends of RSV and influenza, application and operational approach for these ventilations, and how to care for these patients during ventilation and how to feed them. So we are entering into the winter season. We are going to see lots of these X-rays with upper lobe collapse, pneumonia in both the lung fields. The respiratory syncytial virus causes more hospitalization in children every winter. As you can see here, you will have the higher hospitalization during winter months, except during 2021, 2022, because of the COVID pandemic, the hospitalization rates are higher in winter months. It predominantly affects children and elderly. As you can see here, this is a CDC slide. In 2023 and 24 season, the rate of RSV associated hospitalization was around 55 per 100,000 patients. Let's look at the global prevalence. This slide is too crowded, so I wanted to focus on two areas, developing countries and industrialized nations. As you can see in the bottom shows less than 5 years of age, the incidence of RSV associated hospitalizations, which is 1.7 million in industrialized nations, 31.5 million in developing countries. That's about 20 times higher prevalence in developing nations than the industrialized nation. It's understandable because they have more population. But when you look at the mortality associated with RSV bronchiolitis, the numbers are staggering and shows 900 deaths in the industrialized nations. In developing countries, it was 100,500 patients, which is 1,000 times higher. So you see disproportional higher incidence of death in children less than 5 years in developing countries when compared to industrialized nations. I enumerated lots of risk factors that make the disease worse. The important thing being when the patients present, for example, RSV or influenza or bacterial pneumonia, when it affects this vulnerable population, they tend to run severe disease. Then they stay in the hospital longer, and then they develop more complications. So when any of these patients present with either RSV or influenza or any bacterial pneumonia, I would suggest be proactive in treating aggressively, wait and see approach. Influenza, as we have discussed with RSV, you can see the seasonal trend. It starts around October and peaks in the end of December, then it lasts till the end of March. Now, why are the children at risk for respiratory failure? Because of the following reasons. One, they have a narrow airways. Number two, they have a weaker diaphragms. The diaphragm is the most important respiratory muscle in the body. And they have a compressible chest. So they retract more. It will become very obvious. They will have subcostal, intercostal, and suprasternal retractions. So the work of breathing would be much higher and also high oxygen consumption. In addition, Children have a sticky, sick lungs, high resistant airways, decreased tone, atelectasis and loss of lung volume, increased work, hypoxia, and ultimately acute respiratory failure. Three important things I wanted to enumerate: atelectasis and loss of lung volume, increased work, and hypoxia. They become very prominent manifestations in the presentation in children. In order to assess the patient, we got to have an objective guideline whether the patient, to find out the patient's severity. We identified four parameters: respiratory rate, retractions, dyspnea, and auscultation. Each parameter has given 4 points. 0 point meaning the patient is normal, 1 point usually in milder diseases, 2 points moderate, and 3 points for severe disease. Then you compare when the total score is 1 to 3, it's called mild. When the total score is 2 to 8, it is called moderate. And the total score is 9 to 12, it's graded into severe bronchiolitis. So when the patient belongs to the milder category, assess the work of breathing and hydration, do nasal suction, and reassess. If the patient is getting better, then the patient is discharged home. In moderate category, not only you assess work of breathing and hydration and look at oxygenation, do the nasal suction, give a fluids, and reassess the patient. If the patient gets better, then that patient can be watched a little bit longer in the ambulatory care or emergency department, then they can send home. On the other hand, if the patient has other evidences like poor feeding, hypoxemia, which is not responsive to nasal suction, then those patients needs to be admitted in the floor. If the patient worsens, then the patient goes to pediatric ICU. We have done separate seminar on bronchiolitis. It goes in deep. What are the indications to keep the patient in the pediatric floor? What are the indications to send the patients to pediatric ICU? What are the indications to send the patient home from ambulatory care, from emergency department, and from the hospital? And also it explains when to transfer from ambulatory to emergency department, when to admit the hospital, so on and so forth. Very elaborately done. If you are interested in, please listen to or look at the bronchiolitis seminar that is archived in American Medicine YouTube channel. The respiratory support approaches available to deal with these acute respiratory disorders are low flow nasal cannula, high flow nasal cannula, continuous positive airway pressure, otherwise called CPAP, biphasic positive airway pressure, otherwise called BiPAP. If none of them worked, eventually intubation. In this seminar, we are going to talk about high flow nasal cannula and RAM cannula ventilation. The reason we chose, number one, it is non-invasive. Number two, easy to do. Number three, since there is lots of death happening around the globe, this is more easily doable in resource limited areas. Thus, you can do better care for the patient and prevent mortality. Even in United States, over the past 10 years, the usage of high flow nasal cannula and RAM cannula ventilation has gone up significantly when compared to bivent and also invasive ventilation. How does the escalation of non-invasive respiratory support happens? When the patient belongs to hypoxic respiratory failure of moderate or severe category, start with high flow nasal cannula. When the FiO2 exceeds 40%, that indicates alveolar collapse, then start giving CPAP to reduce the workout breathing and also improve the alveolar distension, thus decrease FiO2 requirement. If the workout breathing and the FiO2 continues to be high, and oftentimes these patients have accessory muscle use, head bobbing, and tachypnea, then you need to move on to BiPAP. If workout breathing continues to be on BiPAP, or if the patient has periods of apnea and desaturation, then ultimately you have to intubate the patient. From our experience, do it right from early on using high flow nasal cannula or CPAP, BiPAP. Both can be done through the RAM cannula. You can avoid intubation in vast majority of the patient. Yeah, there are some subgroup of patients definitely needs to be intubated, needs to be cared for, but vast majority can be easily dealt with high flow nasal cannula and RAM cannula ventilation. This is the information published in JAMA a few months ago. They identified the usage of high flow nasal cannula, non-invasive ventilation, and invasive ventilation over the past from 2013 all the way to 2022. As you can see, the usage of high flow nasal cannula is gone up significantly, except during 2020 because of COVID pandemic. We didn't have that much of usage, and also there was a scare of using high flow nasal cannula because it can disseminate virus. Apart from that particular year, the usage of high flow nasal cannula is continued to go up, while the invasive ventilations remain static. Why do we need to do a high flow nasal cannula? Because invasive mechanical ventilation has many issues, like need for sedatives, usage of neuromuscular blocking agents, decreased mobility of the patient, very potential for airway injury, and potential for oral aversion, especially when you are dealing with influenza and RSV. When you intubate, they usually stay intubated at least for a week, provided they do not develop any kind of complications. As a result, they don't eat by mouth, they develop oral aversion, then you need to have speech and swallow evaluation before you let them eat. Then they toss and turn if you sedate them a little bit lower than deep sedation. As a result, they tend to have airway injury, so on and so forth. The high flow nasal cannula avoids all those complications. The high flow nasal cannula is not just a standard nasal cannula turned up to high flow rates. It is heated up to 37 centigrade with 100% relative humidity. It can deliver room air all the way to 100% FiO2. And the flow rates can go up all the way to 60 liters per minute. The flow rate and the FiO2 can be independently titrated to help the patient's flow and FiO2 requirements. How does high flow nasal cannula works? 1. It is heated and humidified, improves secretion clearance, decrease airway inflammation, and also decrease energy expenditure. And it attempts to match up with the patient requirement. What does that mean? The peak inspiratory flows at rest in adults 30 to 60 liters per minute. It can reach up to 120 liters per minute in patients with acute respiratory failure. the high flow nasal cannula match up with the patient requirement. Thus, it reduces the work of breathing. It also improves functional residual capacity. This is an adult data. For every 10 liters per minute of flow, it increases a PEEP of 1 centimeter. For example, if the patient receives 60 liters per minute, they get 6 centimeter of water of PEEP. It causes alveolar recruitment, increased functional residual capacity, most likely because of added PEEP. It's lighter. It's just nasal cannula. It is not the face mask or nasal mask the children and the patients do not like to have on their face. Another concept called oxygen dilution. When you use a regular low flow nasal cannula, when you do 1 liter, it gives 25% FiO2. When you increase the flow to 2, the oxygen concentration goes up by 4. That is called 4-to-1 rule. So when the patient receives 4 liters of low flow oxygen cannula, the maximum the patient can get is 37%. So when you give 6 liters of low flow nasal cannula at 45% FiO2, the patient also breathes through the mouth. Peak inspiratory flows are higher. So let's assume that he's taking 20 liters at 21%, which is atmospheric air. What is the chance the patient gets the patient's FiO2 in the tracheal area? Most likely it is going to be closer to 21% rather than 45%. This concept is called oxygen dilution. But when you do a high flow, assume the patient is getting 60 liters at 45% FiO2. This patient also 20 liters at 21% via mouth. What are the chances of FiO2 in this patient's tracheal or bronchial area? Most likely it is going to be closer to 4% rather than 21%. So high flow minimizes oxygen dilution. In addition to meeting the demand of the patient, decreasing the oxygen dilution, and also it's more lighter than using face mask or nasal mask. It also increases the functional residual capacity. It also causes another thing called dead space washout. Let me explain what is dead space washout is. When you breathe in, you take atmospheric air with 21% FiO2. When you expire the carbon dioxide. When you inspire again, not only you inspire the atmospheric air, you also inspire the expired carbon dioxide. 1/3 of the subsequent inspiration has from the previous expired gas that has carbon dioxide. When you use a high flow, it causes dead space washout so that the patient doesn't need to re-inhale his own carbon dioxide. When should high flow nasal cannula be used? Selected patients with acute hypoxemic respiratory failure. To prevent hypoxemic respiratory failure such as post-extubation and intubation. In patients with moderate and severe bronchiolitis and the respiratory distress of moderate to severe category. In all those situations, high flow nasal cannula can be used and it works well. This article published in 2015 in New England Journal of Medicine. What they compare is high flow versus nasal cannula and BiPAP in patients with acute hypoxemic respiratory failure. Let's look at the findings. The cumulative incidence of intubation is lower in high flow compared to non-invasive ventilation, which is BiPAP they used, and standard oxygen. even though it is decreased intubation high flow, but statistically different. But when you look at the subgroup of patients with PF ratio less than 200, meaning acute hypoxemic respiratory failure, the incidence of intubation significantly lower in patients with using high flow oxygen when compared to non-invasive ventilation and the standard oxygen. So definitely high flow oxygen is useful in patients with acute hypoxemic respiratory failure. Then the same study looked at the survival rate at the day 90, which is 3 months after the illness. The high flow oxygen group has higher probability of survival when compared to standard oxygen and a non-invasive ventilation. Overall, it improves the survival and decreases the incidence of intubation in those patients. Should high flow nasal cannula be used post-extubation? Let's look at the study published in 2014. In this study, nasal high flow versus venturi mask oxygen therapy after extubation was examined. The data shows those patients received in high flow nasal cannula has higher PF ratio, discomfort related to airway dryness was better with high flow nasal cannula than the face mask oxygen. Fewer patients had intraface displacements because there is none. And oxygen desaturations are lower in high flow nasal cannula oxygen, and they require less intubation than the conventional face mask oxygenation. Those are all of them are statistically significant, as you can see. There was another study done. It is not the patient with prior or ongoing lung disease. These patients were undergone major abdominal surgery. It's called OPERA trial done in France. This particular study looked at extubation into high flow nasal cannula and the usual care. As you can see, high flow nasal cannula patients had less complications than the usual care patients, but the difference is not statistically significant. So the recommendation is the routinely extubate into high flow nasal cannula is not completely recommended, but if the patient is suspected of having acute hypoxemic respiratory failure or anticipated acute hypoxemic failure, it is okay to extubate them into high flow nasal cannula. So let's look at what is a practical approach to the clinical use of high flow nasal cannula. The next slide shows how to do it in a sequentially. When the patient has a hypoxemia, meaning saturation is less than 90%, start with low flow nasal cannula less than 6 liters per minute. If the saturation improves, continue the low flow nasal cannula. If the saturation does not improve or did not improve, start high flow nasal cannula with 50 liters per minute and start with the FiO2 of 100%. If the patient is a child, use 2 liters per kilo. If the response is good, that means saturation more than 90%, continue high flow nasal cannula and titrate FiO2 to keep the saturation 90 to 96. De-escalate the FiO2 by maintaining the flow of 50 liters per minute. If FiO2 is less than 40%, then consider low flow oxygen therapy. This was published in Lancet 2016. The reason I mention is the next slide is going to slightly differ from this particular pathway. If the saturation did not improve with 50 liters in adults or 2 liters per kilo in children, then possibility of intubation. No, you should intubate this patient. Some patients go up to 60 liters. That's the max. This article was published in Lancet 2022. I want to walk through how this one is different from the previous one. If the patient is hypoxemic, commence low flow oxygen. If the patient respond, titrate and wean. If the patient did not respond, commence high flow nasal cannula 2 liters per kilo. Titrate FiO2. If the patient respond, titrate FiO2 to room air. Once stable in room air, stop high flow. Do not titrate flow. This is the difference between 2016 and 2022. If he does not respond, escalate to nasal CPAP. According to this one, practically what we do is we escalate to RAM cannula ventilation. That is our practice. There is another version I need to show it to you because it was published in Peds Critical Care 2023. This article was published from Children's Hospital UC Davis. What they do is they wean both flow and FiO2 simultaneously to keep the saturation 90 to 95 while awake or more than 88 while asleep. And the decrease happened every 2 to 4 hours by 2 liters for the flow and is tolerated to keep the saturation FiO2. And then it gets a little bit confusion because once the FiO2 is more than 0.5 or worsening respiratory scores, or if the RT or RN impression that the child is worsening, then you decide whether the patient goes to ICU status or pediatric status. The weaning is different in both those areas. It is very confusing. I do not follow this particular version of it, but if somebody wants to follow, and I want to give this opportunity to look at it. RAM cannula. The inventor name is Dr. Ramanathan. In fact, RAM came from his first 3 letters of his name. Neonatal is the one licensed to sell this cannula at this point. It was launched in 2011 and it came up with multiple sizes of cannula in 2016. This RAM cannula can provide CPAP, it can provide BiPAP, it also can give or you can do pressure control ventilation through RAM cannula. That is an advantage of RAM cannula over other kind of conduits. CPAP, as you know all, continuous airway pressure. The ventilator delivers one pressure during entire respiratory cycle. It assists to overcome premature airway and alveolar closure. Respiratory therapist or clinician sets CPAP level and FiO2 in CPAP mode. The typical range for pediatric viral illness is 7 to 10 centimeters of water. BiPAP, it's bilevel positive airway pressure. The pressure within the system varies with the respiratory cycle. The pressure control is additional pressure delivered on inspiration. It assists to offload respiratory muscles and thus it decreases the work of breathing. Respiratory therapist and clinician sets CPAP, pressure control, and FiO2. The typical expiratory pressure similar to CPAP, 7 to 10 centimeters of water, and the pressure control 8 to 12 centimeters of water above the expiratory pressure. Meaning if you are setting 7 as a PEEP or expiratory pressure, the inspiratory pressure level should be 15, don't put 8. It's supposed to be 15. What are the complications? One, gastric insufflation. It often happens with bilevel with face mask or nasal mask. Pressure injury because of the interface. Oftentimes it happens in the bridge of the nose and also the bony prominences in the cheeks. And sometimes it can cause pneumothorax. How to secure the RAM cannula? There are three ways. Either you use sticky whiskers, tegaderm, or sticky dots. Monitor for septal breakdown and skin integrity. When you're using RAM cannula or any other devices, always make sure you don't injure the patient. Document any issues and notes. It's very important because the people come on the next shift should be able to look at it and make sure it's not worsening or it's getting better. So when you put it in a nicer way, it is very comfortable for the patient, as you can see here. So put the prongs in the right place, then secure it using, looks like they use a dot one. That means a dot goes on the skin, then there is a flip over it that kind of captures the cannula and secures it. You do it in both the sides so that it doesn't wiggle around. The RAM cannula comes in 4 sizes for neonates. One for micro preemie, second for preemie, and third one for newborn, and finally for infant. They come in different colors so that it's easier to pick up rather than kind of looking at the numbers. This RAM cannula for pediatrics comes in 3 colors. The small one is yellow color, the medium one is teal color, and the large one is purple color. Tips for using RAM cannula. The ideal prong size will fill about 80% of the nares. Attach the 15 millimeter oxygen tubing adapter to the RAM cannula. Insert the prongs into the patient nares, leaving a small gap between the septum and the base of the prongs. One of the 2 complications can happen with the RAM cannula. One is septal injury and another one is skin injury. Secure the cannula to the face with the tubing and cannula holder, as I had shown you in the previous slides. As we mentioned earlier, RAM cannula can be used to provide CPAP. It can be used to provide BiPAP, and also one can do pressure control and pressure support ventilation. The typical ranges of PIP used is 20 to 30, and the PEEP used 5 to 10, and the respiratory rate as needed, and the FiO2 as needed. I want to show you this paper presented in one of the conferences. Usage of RAM cannula in infants with acute respiratory failure secondary to bronchiolitis. As you can see here, it significantly improved the respiratory distress for infants with respiratory failure and decreased need for intubation and re-intubation. The RAM cannula settings they recommend is 28/10 and wean off when you can go down to 26/8. Even though it is kind of narrow level, the point I want to make is the higher level of PIP and the PEEP doesn't actually translate into the intra-alveolar pressures. Most of these pressures lost in the nares and also in the mouth. So as a result, the pressure reached in the lower airway is much smaller than what you see here. In both the conditions, whether you do RAM cannula or high flow nasal cannula ventilation, always have emergency equipment ready. Those are ambu bag and proper fitting mask ready to go at the bedside. Number 2, the most important thing, make sure the oxygen flow meter is not low flow. It has to be high flow meter accessible, and ready to go. Make sure suction catheters are there and in working condition. Elevate head of bed to facilitate postural drainage. Skin protection is the most important in both high flow as well as in RAM cannula. Prior to placing a mask or RAM cannula on the patient, it is important to protect the skin and bony prominences. Apply Kevlar 3 mm skin protectant to areas where there will be a skin contact with mask or cannula. Deodorant should be placed to the cheeks underneath where the cannula will be secured, or to the bridge of the nose and other high-risk areas the mask may push tightly against the face. Tegaderm over deodorant when possible for easier manipulation of cannula without causing added skin irritation. Skin checks should be performed undocumented, often to identify any areas of breakdown as soon as possible. If mask is utilized, breaks for oral care are essential. So you cannot avoid oral care and make sure that the skin is protected even before you are placing the nasal cannula or the mask. Regular nasopharyngeal and chest PT are very essential in the caring of these patients. Choose an appropriate suction catheter size for the patient's nasal passages. Lubricate the end of the catheter. It's very important because we commonly found the irritation from the suction catheter. Slowly and gently insert the catheter into the nose. Pass the catheter several inches until a cough is stimulated and the distal section of the pharynx is reached. After each pass with the catheter, give the patient a chance to recover. You should not completely remove the catheter from the nair during this break. Once the passage through the nair is established, it's helpful to keep this for the next pass rather than starting it over. Continue to suction with the breaks to clear the secretion as the patient is able to tolerate. Troubleshooting. The catheter will not advance in the nair. It is usually done by two-person job, one to hold the patient, another one to put the catheter in. Be sure that the catheter is well lubricated. If it doesn't work, try the other nair. You may need to downsize the catheter if it is too big. If the nair is bleeding, utilize the other nair if possible. Try to allow for longer times between NP suctioning. Parents often need reassurance that NP suction is vital and the nasal bleeding is temporary. Sometimes it's overwhelming for a child to have been traumatized, in their opinion, with the nasopharyngeal suction. Maintaining effective non-invasive ventilation. Assess the patient often to ensure proper placement of the mask or cannula prongs and troubleshoot the fit. It's very important. Prongs can become clogged with the nasal secretions and require intermittent assessment. Ensure patient has an optimal interface in place, like mask or RAM cannula. It is very appropriate for the patient. Some patients are mouth breathers and the mask is necessary for the NIV to be effective. Oxygen is able to be based on patient needs. Wean oxygen to reach our goal of keeping 90 to 96 saturation. Use extreme cough in patients that are vomiting, as this can increase the risk of aspiration. Elevate the head under the bed to aid the postural drainage of secretions. Then, fever. Fever increases the body's metabolic demand. Faster breathing aids the body in decreasing its temperature because you lose evaporative losses. That can cause significant increased respiratory rate and workup breathing. Fever management is essential for many patients to breathe more comfortably, and use Tylenol and Motrin, in the United States called paracetamol and ibuprofen, if age and medically appropriate, should be considered to stop patients from spiking temperatures. Motrin is not to be used in patients less than 6 months. Decrease stimulation as much as possible. Avoid unnecessary stressors like blood pressure measurement, IV placements, lab draws. It's better to cluster them with other cares. For example, if you're going to do suctioning, do the suctioning, blood pressure, lab draws together rather than like every 10 minutes apart or every an hour apart. Tylenol and Motrin for comfort PRN is okay to do that one. Outside United States called paracetamol and ibuprofen. Next question is when to feed. Is feeding safe in children with bronchiolitis requiring non-invasive ventilation? Let's look at the data. It's a retrospective analysis of feeding practices in patients with critical bronchiolitis on non-invasive respiratory support, published in 2021. It's kind of interesting. And data came out of Children's Hospital Omaha. They were using RAM Cannula significantly in higher numbers. Out of 64 patients, 52 patients were in RAM Cannula. And out of 114, 108 patients were receiving RAM Cannula. It's kind of very significant in my opinion. And look at the way the patients being fed. This particular study did not include high flow nasal cannula. It included only the RAM Cannula patients predominantly. Out of all these patients, 10% of the patients were fed by mouth. The remaining 90% were fed either nasogastrically or nasojejunally or GT or JT2. And the other thing is interesting was the evidence of aspiration was seen in only one patient out of 109. And the bolus feeds were given in 22%. Almost 80% was receiving continuous feeds. So the feeding is essential to comfort the patient. It can be done safely, but you need to assess the patient case by case basis. The factors to be considered before feeding by mouth are: look at the patient's workout breathing. If the patient is grunting, sputtering, or desaturations while trying to eat. What is our respiratory score? Is it increasing or is the abdomen is grossly distended, or the patient is interested in pure feeding? All needs to be considered before allowing the patients fed by mouth. Pediatric is the best option to start with while determining if the patient is able to tolerate feeds. Nasogastric tubes feeds helpful for feeding and decompressing air from the patient's stomach. Most of the patients receive nasogastric feeds anyway. However, assessment for impending cannula or mask function is necessary. It's recommended to do a NP section prior to feeding. This helps decrease the risk for vomiting and also makes pure feeding easier with clearer breathing passages. This concludes this seminar. Thank you for listening. If you have any concern or question, please leave it in the comments. And if you like it, use it and disseminate to your other people. And we do provide or we give seminars in different subjects every Sunday at 7:30 a.m. Central or 6 p.m. Indian Standard Time. Thank you so much. Appreciate it.